So what we will be seeing together today is really this. So I will just remind quickly the advocacy and the actions that EURORDIS has already initiated on mental health for people with rare diseases, so that you have the overview on where this survey is coming from.
I'm sorry, Jesse, we are hearing you very low. I don't know if your microphone went far away from you.
Is it better now?
Yes, I think a little
Yes,
bit.
so I need to keep my microphone very close to my mouth.
Thank
I will
you.
do that. Thank you. So I will just go back to the way we shaped or designed the questionnaire and who we also involved in the analysis of the questionnaire and of the survey. And then we will have quite some time to look at the key findings from the survey. So we will go together through what you will be able to find in the fact sheets that we have published just now, and also where you can find this information in the dashboard. So both the European dashboard, but also the dashboards that patient organization will receive after the webinar for their own community. And then because, as you can imagine, or for those of you who already watched the presentation that I did of the results during the last European Conference on Rare Diseases, uh, well, of course, the results are not very encouraging for the mental health of people with a rare disease. So we thought that it was quite important to present some initiatives of patient organizations and what they have developed to accompany people with a rare disease in terms of mental health, but also more generally of psychosocial care. And then we'll have a Q&A. But again, if you have any question, you can just ask them in the chat, and we'll try to answer them through the presentation if there are many of them. So a quick reminder of EURORDIS. Most of you do know EURORDIS, but just a reminder on the fact that we cover several topics and we have several activities, but that, as you can see, what is at the center is people first, and how do we make sure that it's people first? Because we base any action and advocacy that we have on evidence and experience of unmet needs and preferences. And so that's, of course, what we've done also when we look at mental health and psychosocial care. So this is why we have conducted the survey, which is really going into helping us going towards our vision of a world where all people living with a rare disease can have longer and better lives and can achieve their full potential in a society that values their well-being and not just their health, and leaves no one behind. So to do that, we have defined also 6 priority areas, and one of them is to contribute to several goals. And those goals, some of those goals are to make sure that we have that all people living with a rare disease have access to integrated medical and psychosocial care with a holistic, lifelong approach and inclusion in society, with a goal to reduce the social, psychological, and economical burden by 1/3 by 2030. And so the approach that was developed by Matt, that it started the initiative, the EURORDIS initiative on mental health, along with members of the network that was also developed, is really to have those 8 pillars. So for psychosocial care, so the first pillar is holistic care. We have prevention, family orientation, person-centered, resource orientation, supportive therapy, orientation towards the rare disease journey, and interdisciplinary cooperation. And you see that this initiative was really relying on several aspects. And one of them, I will just talk about this second pillar here, is the generation of evidence. So there were two literature reviews that were conducted, and we relied on those literature reviews to conduct this survey, this population survey. And just a reminder, if you want to go so the two reviews, the one in the middle and the one on the right, the two literature reviews that we used as a basis for the survey, and also the position paper that was developed with the Mental Health Network, which is so far an outline position paper, because it will now, what we have left to do is to update it based on the results of the survey. So you can have a look at them. And now I will focus a bit more on the survey to remind you how we designed the questionnaire and also how we involved several people even in the analysis of the questionnaire. So a reminder also for those who don't know Rare Barometer. So Rare Barometer is the survey initiative of EURORDIS that is really here to support evidence-based advocacy and action. So it's a not-for-profit initiative. It's an independent initiative, meaning that only EURORDIS staff and EURORDIS board mostly can really give orientations and define the topics, for instance, of the different surveys. It was created 10 years ago now to collect opinions, experience and opinions, and transform them into facts and figures to feed not only the work of EURORDIS, but also of the whole rare disease community. So we still have 25 languages. We will soon have 27 languages because we will be able to add Georgian and Macedonian. And we have now usually around 10,000 participants in our surveys and up to 13,000 participants. So we actually have now more than 25,000 people in the panel that we have, meaning that it's people who agreed to receive our email invitations whenever we have a new survey to participate in the survey. And we share the results always, the collective results, with participants, with patient organizations, decision makers, and the wider public, while making sure that we are GDPR compliant, meaning that the information that is shared with us is only accessible to the Rare Barometer team and saved on secured servers in France. So this is really the program and the framework which did the surveys for disease community on mental health. Through Rare Barometer, we defined three main goals together with our colleagues and with our expert committee. So the first goal is really to understand the specificities and the unmet needs of people with a rare disease and their family members regarding their quality of life and well-being. We also wanted to measure the psychosocial risks that are associated with living with a rare or an undiagnosed condition, and to compare those risks with those encountered by other populations, general populations, but also other people with other diseases. We also wanted to identify the protection and risk factors to the quality of life and the well-being of people with a rare disease and their family through their lives and their care pathways. So to do that, as I said, we relied on two literature reviews that identified specific needs, challenges, and resources of the rare disease community. Then we gathered a committee of 21 experts who were consulted to provide inputs into priority topics and to also choose the instruments, meaning the questions or the questionnaires, the existing questionnaires that we wanted to use in the questionnaire. They also tested the questionnaire, which the EURORDIS national alliances representing all rare diseases in a country and the European federations representing one rare disease or a group of rare diseases in Europe. They also had this occasion to provide feedback on the questionnaire and to test it online. And we also relied, so we translated the questionnaire with AI in 25 languages, and we then relied on professional translators and native speakers from the rare disease community to review the questionnaire. And you see here the list of the 25 languages in which the
Sorry,
questionnaire.
Jessie, we can't hear you anymore.
Oh, can you hear me now?
Yes, but very low.
Very low. Okay. Maybe we can try something. I will stop sharing. Fatoumata, could you please share your screen? Maybe that would be easier in that case.
Is there no issue with your closeness to the microphone?
It may also be my connection.
This is good.
Now it's better.
It's good.
Yeah.
Okay, good.
I'm still sharing. Do you want me to stop?
No, you can continue to share. I think it's better because I'm not sharing anymore. So could the
Okay. So, okay, yes.
Yeah. So the next one and still the next.
Oh, sorry.
Thank you. And so the survey was open for 3 months, and I keep the suspense a bit on the number of participants, but you will see in the next slide, just to let you know that, so that we closed the survey in December. And since then, we've been working quite a lot because we had many participants. So we started by cleaning the data, coding the data, checking the data to make sure that it was fit for analysis. Then we spent quite some time analyzing it, making sure that it was ready to be presented easily in a fact sheet, in the dashboard, but also in the report. Then we shared those preliminary results in March during 3 meetings. One meeting with the expert committee that we gathered, the 21 people we gathered. One meeting with our national alliances and European federations, and also a meeting with the staff from EURORDIS. We gathered all this feedback. We used it. We really made sure that we took into account what people told us. And then we created the fact sheet and we translated it with AI again and relied on the community to check those translations. If you can go to the next slide. And so we had really a large participation. So you see more than 10,000 participants in Europe, almost 10,000, 9,900 in Europe. And worldwide, that represents 94 countries and more than 1,700 rare diseases. So just a reminder, because we don't always do exactly the same. So we always allow or invite all people living with a rare disease and their family members to participate. But because the survey was about mental health, we asked this time the family members to answer for themselves and not just as a proxy for the person living with a rare disease, because we really wanted to see what were the specificities of caring for someone with a rare disease to make sure that we could have everything to be able to help family members of people living with a rare disease. Also, something quite important is that participants, as always, but that may have some implications, were reached out through the Rare Barometer panel and also through EURORDIS networks and through the networks of its member organizations. So it means 2 things: that the survey was online, and also that we reached out to people who were already kind of included into communities because they already accepted to participate in the Rare Barometer panel, or they were already part of the networks of patient organizations. So we didn't reach out to probably those that were the most isolated, we can imagine. If we can go to the next slide. And so relying on those 10,000, close to 10,000 answers, we looked at the results. And just to, before again getting to the results, what I'm going to show today is really the results as they, well, as they are in the fact sheet that is available now. So you have the link here. You can also have the link in the chat. Someone is going to add the link in the chat. And so you have a long fact sheet of 8 pages, which is only available in English. And everything that I will show today is in the fact sheet. And there is still more in the dashboard. If you can go to the next slide. So the dashboard really presents all the answers to all the questions of the questionnaire. So that's more than the fact sheet. And you will see during the presentation that at the bottom left of each slide, you will see the number of the page of the dashboard where you can find the information that is shown. So that because what will be available for patient organizations will be a shorter fact sheet because we could not adapt the long one. But then you will still be able to find, if you have enough participants, you will still be able to find the numbers in the dashboard that you will receive online. If you can go to the next slide. And just to let you know, so the report is not yet available. It will be made available on the 9th of October. And why the 9th? Because we will have EURORDIS roundtable of companies that will be on really psychosocial care. So the title will be From Treatment to Quality of Life, Rethinking Rare Disease Research and Therapeutic Development. And at this occasion, we will publish the report, which is probably at least 50 pages. And we will also publish the reviewed position paper on mental health. And again, it will be reviewed based on the results of the survey. If you can go to the next slide. And so this is today. So today you have access. You can have access already to the European results on the EURORDIS website. And starting next week, we will start sending emails to patient organizations, to EURORDIS members, and to ERNs. For those that have 30 participants, we will send to the national alliances and European federations and to the ERNs automatically their fact sheet and their dashboard with their own results, meaning for their own community. And any other EURORDIS member that would like to have access to their results can write to us at the address that is just at the bottom of the page to see how many participants they have. And if they have at least 30 participants, we will send them their results also. So what does it mean, sending the results? If you can go to the next slide. It means that we will adapt the fact sheet. So you have here just the first page of the fact sheet. And we will also adapt the dashboard, if you can go to the next page, to show really your results. And so the fact sheets will be sent in one language, but the dashboard will be accessible in the 25 languages of the survey. Next slide. Next slide. And for those who would like their own results, so this is what you would need to send us if it's by country, the name of the country, if it's by disease, the ORFA code, the number of the ORFA codes. So you can go on ORFANet to find the ORFA codes, the languages that you need, and if you and the type of format of file that you need for the dashboard. And we just remind you of the number of participants per country for you to know what you can access to. I won't go in the details. We can go to the next slide. We also have participants outside Europe. So even outside Europe, people can ask for their results if they have 30 participants. Next slide. Per rare disease, you will have access to the PowerPoint. So you will be able to know how many participants there are in your community. So yeah. Also per ERN, most of the ERNs have enough participants to receive their own dashboard. And finally, per European Federation, so you see that some of them, which are quite wide in terms of number of rare diseases represented, have quite a lot of participants, but some of them, it's also just one disease, and they have really a wide dissemination of the survey, of the questionnaire, so they do have a lot of participants, which allow them to have quite in-depth results. And so now we can get to the key findings. And the main finding, actually, we have one indicator, which is the main indicator that we will use. 7 out of 10 people living with rare disease and family members report poor mental health. So what do we mean by poor mental health? We used validated scales, so questionnaires that are really made and validated and tested, and still validated again several times, to measure very specific symptoms. So it is self-reported, of course, because it's a patient survey. So it's only the symptoms that people reported. It's reported through several questions. So when we talk about depressive symptoms, actually there were 8 questions. And we consider that people have moderate to severe depressive symptoms when there is when they achieve a specific score among the 3 questions. So it's the same for anxiety symptoms, also for loneliness and for suicidal thoughts. So we asked people if they had suicidal thoughts in the past 6 months. And what does it mean to have a poor mental health in this survey? It means that people have at least one of those difficulties or reported at least one of those difficulties. So moderate to severe depressive symptoms, significant anxiety symptoms, feeling lonely, or having had suicidal thoughts over the past 6 months. Next slide. So if we look at each indicator, each symptom, what we can see is that each symptom are very high. So no other survey had the same indicator that I showed before, the poor mental health, summing up those 4 aspects of mental health. But if we look at each indicator, individual indicators, so we see that 45% report moderate to severe depressive symptoms, and that it is 7 times more than in the European population. And actually that was measured using the exact same questionnaire. So we can say that it's the exact same way to report depressive symptoms, and we used the same threshold. So in the EU population, depressive symptoms are at 6%, and it's 45% among people with a rare disease and their family members. Also, anxiety symptoms, if you look at the bottom left, 42% have significant reports, clinically significant anxiety symptoms. And again, it is 7 times more than in the EU population. But in that case, we used a scale that is really used a lot, but more for clinical populations. There is no scale for the general population that is widely used. So the 5% that I show, it's not by using the exact same questions that we had, but it's estimations that were made for the WHO. And you will see a bit later that we have other comparisons and with the same scale, but it's not in the EU in the general population. Loneliness, 43%. So again, almost half of the participants felt lonely. And again, this is a validated scale with a specific threshold that we used that is recognized in the literature. And this is 4 to 20 times more than in the EU population. And to look at the EU population, we looked at the existing literature, peer-reviewed literature, using the same scale or similar scales, not always exactly the same. And in the literature, we find 2 to 10% loneliness among the general population in Europe. And suicidal thoughts, almost 1/3 had suicidal thoughts in the past 6 months, which is 5 to 10 times more than in the general population. And again, we rely on systematic literature reviews. So we looked at what we could compare those figures with, because clearly it's really higher than in the general population. So one of the questions that we had was whether we could find other populations, maybe clinical populations or other diseases, people living with other diseases that had the same type of mental health difficulties or psychological burden. And what we found was that we could find the same type of results in the general population during the COVID-19 pandemic. So during exceptional contexts. And I think that's very powerful because it means that most people can relate of the level of anxiety that was felt during the COVID-19 pandemic. And for some of those indicators, like depressive symptoms, but also sometimes suicidal thoughts, we also found the same levels of difficulties in high burden clinical populations or very vulnerable populations. For instance, we found studies in people living with HIV in Uganda that reported the same levels of anxiety, people in psychiatric hospital settings, or people with severe mental disorders that had the same levels of difficulties. I will just pause a bit now because I saw that there were a few questions. So there is a question on the PHQ-8. So the difference between the PHQ-8 and the PHQ-9, for those of you who know it, who know the scale, is that the PHQ-9 is an open question, if I remember correctly, either an open question or a question on suicidal thoughts. And again, if I remember correctly, the question that is in the PHQ-8 on suicidal thoughts, we found it really harsh for people to answer online without any help or without anyone being able to provide any support in front of them, especially because we did imagine that it was a vulnerable population. Also, PHQ-8 is the one that is being used by Eurostat in the general population. So we had enough questions to really compare very robustly with the general population. And we preferred to write ourselves a question on suicidal thoughts. And also we made it not compulsory, optional, so that people who were too disturbed by the question could avoid answering it. Can we go to the next slide? So we also looked at, as I said, poor mental health. We defined it by reporting at least one of those difficulties, but many participants had several of those difficulties. So 47% reported at least 2 difficulties. This is quite high, but we also need to remember that actually depression and anxiety are very correlated. So actually, most of those 47% with reporting to at least 2 difficulties, they reported both depressive symptoms and anxiety symptoms. What is also very meaningful is that almost a third, well, 28% reported at least 3 difficulties and 12% reported all 4 difficulties. And can you just stay on the last slide, please? Thank you. So in the fact sheet, you will find, in the long fact sheet, you will find some testimonies that we took from the survey, from open answers in the survey. And one of them is from a person living with a rare disease in Italy saying that their symptoms prevent them from leading a normal life. Working, socializing, and even studying are difficult. They greatly affect their daily life and altogether cause anxiety and depression. So, yeah, maybe I didn't say that before, but the fact sheet is really made to be presented, hopefully by patient organizations, for policymakers. So the testimonies are really also here to allow anyone who doesn't know what it means to live with a rare disease to understand why there is such a psychological burden of living with coming with living with a rare disease. And we also added the testimony from a parent of a person living with a rare disease in Czech Republic, saying that there are many situations that they don't know how to handle. Caring for their daughter every day, they often feel extremely tired and exhausted and have lost friends and social contacts. If you can go to the next slide. So, as I said, we asked people to report on their own mental health because we wanted to see what were the difficulties encountered by patients and what were the difficulties encountered by family members, so that there could be specific actions taken to help them. And we do have questions on support received and also on coping mechanisms that allow people to cope really with the disease. So that will come. But we first need to see what is going on and what are the specificities for mental health of patients and of family members. So when we look at people living with a rare disease themselves, what we see is that 67% report poor mental health. And you see that the percentage of those reporting depressive symptoms is a bit higher. And also suicidal thoughts, if you remember, it was 31% for all participants, and it's 35% among people living with a rare disease, themselves. If we go to the next slide, we looked at what the specificities or the characteristics of those reporting even poorer mental health, let's say. And more people living with a rare disease report poor mental health when they experience a bad or very bad quality of life. Of course, mental health and quality of life are two concepts that are very correlated. But it is actually even higher than health, if you can see. So of course, when they have bad or when they report bad or very bad health, they also have poor mental health for 86% of them. But you see that quality of life is really higher. So for 85%, they have poor mental health when they have severe disabilities, when they experience pain every day, physical pain every day, when they have many severe symptoms, and when they have already experienced discrimination related to their condition or their disability. And what we saw also, we looked at the age of the participants, and we saw that mental health, more people had a poor mental health when they were under 30 years old, and it improves, let's say, when people are older, or at least people who are older have less of them have poor mental health. And we also see that regardless of their age at the moment to answer the questionnaire, it's also more of them have a poor mental health when they were minors. So when the first symptoms appeared when they were children or adolescents, which is quite important because, as you know, 70% of rare diseases appear in childhood. So we'll just pause now to look at the chat. Yeah, so we do have some questions on support, so we will come back come to that a bit later on. If we go to the next slide. So if we look at parents, you see that the percentages of people with poor mental health or reporting poor mental health is quite similar. It was 67% among patients, 71% among parents. You will find in the dashboard, just to let you know, because we don't only have parents as family members, but most of the family members are parents. So we also have aunts, grandparents, siblings, spouses or partners, but it's less of them. First of all, and so we don't show the results in the fact sheet, but we show the results in the dashboard, so you can have access to the results in the dashboard. And you see that for the parents, what is more, they're more impacted by loneliness and by anxiety symptoms. Depressive symptoms and suicidal thoughts are, of course, also very high, especially if we compare it with the general population. But you see that half of them, more than half of them, felt lonely and reported anxiety symptoms. And again, if we look at their characteristics, the characteristics of those, who report poor mental health more often. On the next slide, we see that more of them report poor mental health when they report difficulties managing the numerous medical appointments, when they report that their child's health is poor or very poor, when they consider that the medical costs that that they have to pay regularly represent a heavy financial burden. When they also say that they often have to explain the condition to healthcare professionals. And when so we ask them if they what was their professional condition, let's say. And so when they are unemployed or homemakers, and when they are single, separated, or divorced, they report also poor mental health. So that gives another idea. You see that it's really the caring, the tasks that are related to the fact that they care for a person living with a rare disease that is really impacting their mental health, and also the impact on their own life when they are divorced, which is more often the case than in the general population, and when they cannot work. And also we asked family members, and especially parents, to tell us also to report their health. And what we found, so we used the same question as the one that is used by the European Commission in Eurostat, and they report less of them report good or very good health. So the measure that is given by Eurostat is good or very good health. And you see that in the EU population, it's 69% that report good or very good health. And for parents of people with rare diseases, it's only 53%. So we didn't only want to look at their difficulties, we also wanted to look at the support they received, and so that we could see if, for instance, some type of support was useful and was maybe more useful for one type of participants compared to another type of participant. And we looked at the support that they received through the care pathway. So we asked which support they received at 3 points in time. So this is the first point in time, which is before diagnosis, or while they were still searching for a diagnosis, or for those that don't have a diagnosis yet, since the first symptoms were noticed. We also asked them at diagnosis, and then in the last 6 months, which support they received. Can you go back to the last one? So for during the diagnosis search, what we see is that 50% of them report that they didn't receive any psychological or emotional support. 35% said that they received emotional support from family, friends, and neighbors, and 14% from the rare disease community or from a charity. And only 25% that said that they received support from mental health professionals or from healthcare professionals, which we consider as professional psychological support. And we looked at the time to diagnosis, how long it took them to from the first symptoms to the diagnosis, to the confirmed diagnosis or the initial diagnosis. And what we found was that those that received no support, it took them longer to get a diagnosis. So we don't know if it's the support that helps the time to, well, that decreases the time to diagnosis, or if it's the other way around, that people with more support also have a shorter diagnosis. But for sure, there is a correlation, a statistically significant correlation between the fact that people have access to emotional or psychological support and the time to diagnosis. And this is also something that we saw in our survey on the time to diagnosis. So this is something we wanted to dig into for this survey. And we use in the fact sheets a testimony that allows to also explain, at least for one particular case, what could be the link between psychological support and the time to diagnosis. So we have this parent of a person living with a rare disease in Romania who shared her experience. And so she said that they started physiotherapy for their son after his birth, but they saw no improvement after 3 years. They began searching for a diagnosis on the internet, and she found an obvious answer, but that was so devastating that she could not accept it. She says that she was in complete denial, and because she had no support from anyone, she stopped searching for answers. And it took her a year and a half, because her son developed new symptoms that she could no longer deny, to resume her search for a diagnosis. Then it took her another 2 years to confirm the diagnosis with healthcare professionals. And that's in total 7 years, visiting doctors every couple of months and wasting public and family resources instead of focusing on appropriate treatments and making sure that her son could find his place in society. If you go to the next slide. And you see that the numbers are quite similar. Sorry, if we look at emotional and psychological support received at diagnosis. And we chose to use or to copy, let's say, the testimony from a person living with a rare disease in France who didn't have emotional support or psychological support at diagnosis, and who says that she was never properly informed about her condition or what could be done to improve the situation. And what affected her most and was hardest to accept was being told that her condition was chronic with no real cure and only stabilization. So that was difficult to accept. Especially as a teenager, she struggled to accept the impact of the condition on her appearance and the way she dressed. Maybe just some time to look at the comments. So, Andre, yes, there may be a common factor that could be possible. I'm thinking about, yeah, but for sure we asked the question currently 2 times in 2 different surveys, and we see this very high correlation between access to psychological support and time to diagnosis. So yes, it could be access to healthcare. There could be a factor which would be having the resources, not only the financial resources, but also the cultural resources to access support. But that probably also means that if we improve access to psychological support during the diagnosis search and we don't wait for people to be diagnosed, we may have a chance to improve time to diagnosis, because I think that the testimony that we had is quite impactful in the sense that this person is really saying that she was in denial. And probably if she was helped just dealing with her emotions, she could have been in denial for a shorter amount of time and would have continued to search for a diagnosis faster and not wait for a year and a half. Um, so yeah, so we have several questions on countries and conditions. So the results per country and per conditions, we look at them for some questions in the report. So you will have to wait for the report. Not so much for the condition. We don't look at individual conditions. We do look at some countries, but we also mostly look at the difference between Eastern Europe, Northern Europe, Western Europe, and Southern Europe. However, starting next week, the patient associations that are members of EURORDIS will receive their own results. So if there are patient organizations that you saw in the previous slides that have at least 30 participants, they can have access to the results if they are a EURORDIS member. So I would really encourage anyone who would like to have access to those results, if they are not a EURORDIS member themselves or not a patient organization, to contact those patient organizations to tell them, if they don't know about that already, that they can have access to the results for their community. And then they kind of own their results and can share them with whoever they want. If we go to the next slide. So we also asked, as you've seen, about the support received by family or by the community, let's say, by their social environment. And we analyzed it a bit specifically. So we saw, because we asked them if they received it, but also if they needed it. So or if it was enough to cover the needs. So 65% said that in the last 6 months, they received emotional support from their family, friends, or neighbors, but also 38% of them, of those who received this support, say that it was not enough to cover the needs. What does it mean? It means that it's important to have this support, that most people do receive this support, this emotional support from their social environment, but the needs of the rare disease community are so complex that probably no family member is equipped unless they're a professional healthcare healthcare professional or mental health professional, and yet when it's your own family, it's quite different. None of them is equipped really to cover the needs, the psychosocial needs of people with rare disease and their family members. However, the social environment can also have a poor effect on mental health when it is discriminatory. So we ask people if they experience, well, we ask patients really if they experienced discrimination from their social environment, also from other sources, but especially from their social environment. 33% said that they did, that they had already experienced discrimination because of their rare disease or disability. And among them, 85% report poor mental health. If you remember, in all patients, it was 67%, so it's really higher. More of them do report poor mental health. So there is, again, a high correlation and probably an impact of discrimination in the family and in the social environment on mental health. If you go to the next slide. So on the third time point that we already covered with the last slide, we ask people which kind of support they received. So here we focus on the professional support, professional psychological support, and we ask them if they received this type of support from centers of expertise, from reimbursed mental health professionals, from non-reimbursed mental health professionals, and from general practitioners or nurses. So this doesn't show here, but you will have the results in the dashboard. But actually, the support they received mostly among professionals was from general practitioners and nurses. So they're really at the forefront with the family members to provide this emotional or psychological support. But what you see here are the figures for the unmet needs. So for those who said that they needed this type of support, we looked at how many of them received it, actually. And we see that the highest unmet need is to receive psychological support in centers of expertise, and then to receive psychological support from reimbursed mental health professionals, from non-reimbursed mental health professionals, and from general practitioner or nurses. So it's still high, but it's lower than from centers of expertise. If we go to the next slide. And so we have very high unmet needs, 55 to 75%, depending on the type of support or of framework of institution from which they could receive it, or people from whom they could receive it. And yet we see that for those who accessed professional psychological support in the last 6 months, most of them report that it helped them. So we have more, you will see in the report, we have more ways detailed on how it could help them. These are the most cited, the most quoted. So 72% said that it helped them to better manage their daily life, including stress or anxiety. 65% to develop more skills to face challenging situations. 62% to live better with the symptoms of the condition. 56% to better deal with the constraints related to the treatment or with the lack of treatment for the condition, and 49% to improve their ability to focus on work or studies. And we had this possibility of answer, especially because you may know it, but the way the WHO defines mental health is the ability to work and study normally, let's say, as anyone else. And so we, again, added here some testimonies for people to understand how such professional psychological support could help. So we have one person living with a rare disease from Belgium who says, who reports being part of a support group with other people living with the same condition, led by a psychologist at the neuromuscular center. And the group is very supportive, like a second family, where they share helpful tips and tricks. Another person living with the rare disease in Italy said that the private psychological support they received for the past 5 years helped them focus on the positive aspects of their family life and find the strength and energy to face new projects and challenges. It gives them the confidence in the future and helps them keep pessimism and negativity at bay. And we have a testimony from a parent from Germany saying that their personal resilience has been strengthened through psychotherapy and exchanges with self-help organizations. So we see that psychological support helps, that emotional support also coming from the social environment helps. And so then we also ask them some questions about what, for those who access psychological support, what that represented in financially. So you can see the question that we used. We asked them if that professional psychological support represented a financial burden in the last 12 months. And the reason for that is that it's really similar to a question that is used, and you see it on the second part, on the right part of the slide, by Eurostat, so by the European Commission, to assess the financial burden of medicines and of medical examinations in Europe. So for professional psychological support, we see that for 64% of those who accessed it, that represents a burden. So somewhat a burden or a heavy burden for 32%. And this burden, this financial burden, adds to the financial burden related to medicines and medical care, which is already higher in the rare disease community, of course, compared to the general population. And you have the figures here. So in the general population, medicines, for prescribed and non-prescribed medicines, 12% say that it's a heavy financial burden, and it's twice as much in the rare disease population, at least in the survey. And For medical examinations or interventions, in the EU population, 13% say that it's a heavy financial burden, and it's 20% for rare diseases, for people with rare diseases. And if you can stay on the last slide, something that is also quite important, which is not shown here, but that is can also be said when presenting those results, is that we can also expect that any cost or any money spent on psychological support can also probably help decrease the costs of medicines and examinations, because we do have quite also a lot of studies showing that people receiving psychological support can also have better treatment adherence, care adherence, go to their medical examinations also more often. And so probably we can imagine, it doesn't show in the survey, but we can imagine that access to psychological support could also help limit the burden, the financial burden of medicines and examinations. If you go to the next slide. So we also asked people if they ever encountered barriers so that we could work on those barriers at different levels. And so you see how we asked the question, if they ever encountered barriers to access professional psychological support in their lifetime, so whether they accessed it or not. 27% said that they could not access it because of logistical barriers, including costs, but also access, waiting lists, availability. 20% said that they didn't know how to access it, and 90% that they did not feel ready. Meaning that, so the 55% is not just an addition of the 27, 20, and 19, because it's a multiple choice question. But when we add up all of those answers, 55% report barriers. So majority report barriers in accessing psychological support. Only 17% report no obstacle. And 27% said that they did not encounter barriers and that they did not need professional psychological support. However, among those 27%, 4 out of 10 report poor mental health. So at least one mental health difficulty, which is lower than among all participants, but it is still higher than in the general population. So you may also very well have people there who say that they do not need to access professional psychological support, but that may actually need it because when we measure their mental health or their self-reported mental health, they do have a poor mental health. So this is really what you see in the fact sheet, the results that you will find in the fact sheet. Again, there is more in the dashboard. There will be more in the report, especially in terms of solutions. As I said before, we had discussed those preliminary results and what we should include in the fact sheet with patient organizations. And with them, we agreed that because this fact sheet is really made to bring evidence to policymakers, to healthcare professionals, to decision makers, we wanted to focus on the difficulties encountered and on the obstacles so that we could work on those obstacles and those difficulties with them and raise awareness among healthcare professionals and decision makers, really, and policymakers. But there's more. There will be more in the dashboard and in the report to guide action, especially for more patient organizations, but also from healthcare professionals. So it's not finished, also not over the analysis and how we can accompany people. And I didn't want to leave everyone on just the observation that it's hard to live with a rare disease and that it does impact mental health. I also wanted to leave you with some solutions. And for that, I invited Dan from Alan Maladies Rares Luxembourg to present their initiative of consultations of the help they provide, the psychosocial help they provide in their organization. And we also have the recording, because she couldn't be here today, of a researcher a psychologist who developed in Germany a program of peer support among people living with a rare disease. So I will leave the floor to Dan.
Hello, can you hear me all right?
Yes, we can hear you very well.
Good. May I share my screen now?
Yes, you should be able to share it.
So is this working?
It is working. We can see your screen.
Good. And you see the pointer.
We do.
Victory. All right. So thank you, Jessie, for the opportunity to present our psychosocial care support service. I will go swiftly through this presentation. If at any time you want to interrupt me to ask questions, please feel free. And I suppose that we'll have a possibility later on to ask some more questions if you like. So, Maladie Rare Luxembourg, Alan, is a non-for-profit association of public utility that was founded in 1998. So we are almost 30 years old. In 2 years we'll be 30. So a young adult in its full power, I would argue. And in the beginning, the focus was more on neuromuscular disease, but very quickly, the parents that founded this association realized that it's useful to present all rare diseases because they have the same challenges. So we have a vision fostering an environment for people living with a rare disease to realize their full potential through recognition, equal opportunities, and improved quality of life. And this is reflected in our 3 core values: integrity, empathy, and team spirit. We have the structure of the organization is very classical for Luxembourg, with a general assembly, board of directors, management, and then 4 different, I would call it departments, but that's a bit oversold, except maybe for the psychosocial counseling service, where we have 8 people working, and that's 7.8 full-time equivalent. We also have a recreational activities service. I won't talk about that today, but this may also have a good impact on mental health and the support people may find there. So the focus now is only on this part on the left. Our objectives are mainly to improve mental health and emotional well-being, to facilitate social inclusion, and to reduce daily stress. This is a little bit an overview of how we function. If a person has a suspected or confirmed rare disease, they can contact us through the info line Maladie Rare. That's a national service, if you like, with a well-known telephone number and email address. And people can request support through those channels. And they will get a first series of assistance and maybe counsels, tips and tricks. Sometimes we will refer them to what we call the cellule d'orientation et de coordination nationale. So a national support cell, if you like, where we have social workers from our team and medical doctors from the main hospital in Luxembourg that meet every week, every Tuesday morning, where we discuss the cases that have been addressed either to us or to them. And then, if it's needed, we will get them into our second line of support, and that really will concern all aspects of daily life, from finding their way through administrative proceedings to issues related to work or school, the best orientation through the medical pathway, mental health, social inclusion, and so on. So the request comes in via the info line. And when we get into the second line stage, there will be a first consultation that will be always planned with a psychologist and the social worker. This combination is interesting because oftentimes the requests have multiple layers and multiple aspects, and the combination of those two expertises is really interesting because everybody can join in and give their best counsel, and we see where we take it from there. The next step is to co-create with the patients a support plan where we help them identify the current situation, the priorities. There may be some deadlines for the kid to go to school, or maybe some deadlines for therapy and so on, or for reporting at work. And that will be the priority list and the support plan. Then if people request it, they will have access to psychological support. That can be anything between 2, 3, 4 sessions just to help them get back on track, to more regular, maybe on a monthly basis, follow-up. But that's only if requested, and that's just as well for people who are directly affected by their rare disease, but also support family members, parents, brothers, sisters, and so on. And then we have the social part, where you can see this as some sort of case management, where we try to coordinate the care, first of all, but also the administrative steps that need to be taken to ensure access to their social rights. And that's the social worker who will take care of that aspect. At one stage, there will be an evaluation of the support plan and a decision of continuing or discontinuing one part or the other of the support plan. So how is this located in our general context in Luxembourg? The National Info Line and this common cell from the medical and psychosocial point, these are really new services that were created within the first national plan of rare diseases for Luxembourg, which started in 2018 and went on through to 23, because the COVID year allowed us to have one extra year in this plan. This allowed us to hire more staff and further professionalize, strengthen our network. This is really a very important aspect, because we got into touch with a lot of stakeholders here in Luxembourg, and it shortened the way to get the right support in the right place, and maybe get to know some people from administrations and from different hospitals. And it definitely increased our visibility. Some challenges with this approach. Well, obviously, the coordination within the team is a very important aspect. As I said, we have 8 people that are employed in this service, 3 psychologists/psychotherapists, and 5 social assistants. They meet on a weekly basis to go through the new requests for support and to assist each other to see if some things get stuck with certain situations, how to move on best. We have strict inclusion criteria and refer ourselves to Orphanet to make sure that people who request support are indeed concerned by rare disease. Sometimes this is a little bit complicated, because in some areas a disease could be rare and in others not. Some diseases used to be rare but no longer are, and others that are rare, that are obviously there, that are not yet referenced in Orphanet. So we have to look occasionally at the scientific literature to take a decision there. Unfortunately, we have to prioritize requests, because, as I will show you in one of the next slides, we have a lot of requests for support, and sometimes we have emergencies, situations that really need immediate action, like very quickly developing diseases that need immediate action. There are cultural differences in the people that come to seek our assistance. You must understand that Luxembourg has approximately 50% of its inhabitants that are from different nationalities. I don't remember exactly the name, but probably something like 100 plus different nationalities. So we have different cultures, different backgrounds, different educations, different belief systems that these people have, and we must be respectful of those cultural differences, which is not always easy. If we take a more scientific approach to things, we know that some things are delusional, but then how do we get this to the people, to the patients? That's another pair of gloves, and we have to take really good care not to overwhelm them and not to disturb their own belief systems. We have to stay up to date, so continuous training is a big key word, and we take care to get our people into trainings and stay up to date with the new findings from the literature. And one of the main concerns is to navigate the system. You can have a very good national system, and I think Luxembourg is probably one of the best social security systems, but then you have to know how to apply, in what sequence, and oftentimes people from administrations will look at their tables and find the disease isn't in their tables, so the first reaction is often a refusal, and then we have to know how to get this back on track. So a lot of communication. Communication is really a key word in our team with weekly team meetings. We also have a custom-made secure database where every intervention is documented, and we have notes that everybody takes. So if somebody gets ill from the team, somebody else could take over that patient, and we would be up to speed very quickly to know where the situation stands and how to move on. Team support is very important because obviously some situations are really difficult. So they have a lot of interventions between themselves, and we have approximately a monthly supervision with an external expert where particularly hard cases can be discussed, and so we get an external opinion on how to move on. Continuous training, leadership is important to make this work out. And then the attitude of the team, I must say I am extremely fortunate to work with a great team who have a lot of respect, a lot of empathy, transparency, trust, and the focus on patient goals at all times. So the service is free of charge. Jesse mentioned a few barriers, costs being one of them, and we can afford to make it free of charge because we have a convention with the Ministry of Health. Unfortunately, this only covers part of our expenses, mainly human resources, and I'm fighting every year to get a little bit more, but everybody's fighting, so it's a hard competition. But on the other side, we get a lot of donations, and so we have to nurture our reputation with respect to service clubs, companies in Luxembourg, and so on. We are very fortunate to have a very multilingual team where we can provide assistance in German, French, English, Luxembourgish, of course, Portuguese, Italian, and Spanish. And for other situations, we have to ask a translator. So it's a patient-centered and needs-based approach. We have accessible office space, and our staff is really specialized in rare diseases. That's a hard nut to crack because oftentimes when we recruit new people, it's not an easy area where people come always very freely because we have hard work to do, and we have a lot of work. So we reach approximately 660,000 people in Luxembourg, but you must know we have a lot of cross-border workers coming from Germany, France, and Belgium working in Luxembourg, and they are also enrolled in the National Social Security System. So we're looking at probably 950 plus thousand people who are potentially eligible for our support. And this translates into a lot of requests for assistance. You see here the change over the years. Last year we had 752 requests for assistance for only 8 people. So that's really a lot of work. And we must admit we cannot handle them very, very closely in time, at least not everybody. Of course, the emergencies we have to look at very quickly. Remember also, I mentioned the first national plan for rare diseases, which started in 2018, 2019. We have the COVID year here, but you see, which I would interpret as an effect of our increased visibility, and we get more and more people from hospitals, medical staff, doctors who send patients to us. This slide is in French, so sorry for that, but I will explain it. It illustrates the multiple activities that our team performs, from discussing with patients on the phone or via email, some 20%, to discussing with other professionals, healthcare professionals and others. A lot of time, a quarter, goes into looking for information. And even though we have good expertise, and it's almost a contradiction in itself to say we have expertise in rare diseases, given the 7,000 plus rare diseases that are out there, so we cannot possibly know all the rare diseases, and we have to go and look up things. Then meetings with the network in Luxembourg, and then 40% of consultations in the presence of the patients, where we either accompany them to administrations or to medical visits, meetings with the networks, a lot of psychological consultations that make up the bulk of our activities, but then also social consultations. So in short, 8 co-workers on this team, 5 social workers, 3 psychologists, 4 consultation rooms. We even have 2 company cars that we got offered a long time ago from the foundation. I would argue that they cost us more money than they actually help us, but that's a different story. We have, of course, personal office space, accessible building, and a training budget for the team. In terms of social development goals, we see ourselves as under the SDG 1, 3, and 10. So that's it in a nutshell. Oh yeah, I forget, we got a label from the European Commission in 2024 as a promising practice on mental health for rare diseases. So we're proud to show that around. I almost forgot that, which is nice. And I like to highlight that also in my meetings with the politicians and the minister, where we ask for more support. And so these are good arguments for us to put forward. If you'd like to contact us, you'll find us at alan.lu, and you will find the other contact details there too. That's it. Thank you.
Thank you very much, Dan. We have several questions in the chat. So one question from Gerrit Jan, who says the approach from Dan is very professional, but looks very much like a healthcare provider. While he can envision patient communities' mental support, but this almost looks like work we expect from a healthcare institutions.
Yeah, that's a good point. And maybe one aspect that you can remember is that we've been around for a while now, and we've really professionalized our approach over the last years. If I go back very quickly to this slide here, this used to be a patient association like you find so many, with a lot of volunteers and a lot of goodwill and a lot of work and personal involvement, but that's very draining. It costs a lot of personal resources for parents to do this. And it was possible over the years. And actually, as of 2019, I got the possibilities to have 4 employees financed via the ministry. We're now up to 7. Yeah, 7 employees. And that's the bulk of the money that we expend. But we were able to build this up over the years. So don't be impressed by the step. It looks like a huge step if you start from scratch. But of course, this is something that we built up progressively. And yes, we have reached a good expertise again through continuous training. We work closely with medical doctors and geneticists from the national laboratory for diagnosis and so on. We are involved in the second national plan for rare diseases, and we enjoy, I think, I would argue, a reputation as a serious partner, and we contribute a lot to those things. So maybe you should say this to our minister, because she actually saves a lot of money by the fact that we finance ourselves on our own up to 25%.
And actually, there's also a question or a remark, a comment. So Joanna is saying that it is a wonderful model, as the point of support, but that actually everything depends on the national plan.
Well, yeah, it existed before the national plan, but as you can see, this was scaling up slowly, and we really took a leap here as of the year following COVID, where we gained traction with our network and our involvement with other stakeholders. So yes, the national plan is definitely a good route to take. So if you in your respective countries envisage or have a national plan, and there are aspects like a national info line or a national helpline or national support group, these are things you can push forwards through that plan. Oftentimes, at least in our case, it used to be like, okay, there's a new initiative like the info line. It was started as a pilot project, and then my job was to show after 2 or 3 years that this was useful. We had to show statistics. That's why we have our own database where we report a lot of what we do. And this is only what I show here is only one metric, the number of requests, but I have tons of metrics that I can use and show to the policymakers to tell them, look, this makes sense. You have to keep supporting us, and we even have to ramp it up. So metrics is definitely a key.
Actually, Julie has a question also, which is a bit related to the national plans, but not really. She was wondering if you also aim to scale in other countries.
If we scale in other countries, is that the question?
Yeah, or if we intend to scale in other countries.
Well, not really, because we gain most of our resources from the National Ministry of Health, and so I wouldn't expect her to be happy knowing that we would do work in other countries where they have their own National Ministry of Health. Well, what we do, I mean, we do collaborate with EURORDIS, and since we have a good team that are interested, that are informed, we can afford to be present in several working groups. For example, what I'm doing now, that's something that's understood. But I wouldn't advertise, even if I did it, to the minister that I go do work for other countries. What we do is we can assist and support and maybe give good tips and tricks, but scale things in other countries, I wouldn't expect that to happen.
And Julie is also asking how you guarantee that disease specificities are known or taken into consideration.
Yeah, that's a good point. I mean, we saw last year close to 300 different diseases, if I may put it like that. So the 752 requests represented almost 300 diseases. We don't know them all, and it regularly happens so that we receive a patient with a diagnosis, and then we have to do our homework first of all. We have the advantage of knowing where to look and what is important. For example, if you have a myopathy, you would know, and that's progressive, you would know that maybe you have to look at the natural history of that disease and foresee if at one stage some technical aids would be required, or if the family will have to change their home because they're living in a small apartment. But if the boy needs an electric wheelchair in the next 2 or 3 years, then it's already time to start looking for something new. So we have to gain our own experience but that's maybe on a case-by-case basis where we have to do some reading in the scientific literature.
Thank you.
And of course, Orphanet has a lot of resources. That's really our main source of information.
And Gerrit-Jan is also asking another question. If you limit your service to people with rare diseases, because that could also be beneficial for people with non-rare diseases. And if you limit, how do you handle the calls from people who are not living with a rare disease, if you have any?
Yeah, excellent point. Yeah, we have an algorithm of verifying the inclusion criteria, and sometimes after already some interactions, we realize, oh, this is not a rare disease, and unfortunately, we have to apply our algorithm because that's our mission that we get from the ministry. And if we didn't have so many requests as we have here, it wouldn't matter very much, and we could afford to be a bit more broad. But we have to really narrow it down very strictly because we are overwhelmed with requests. And what we do in those cases, we have a portfolio of other institutions or associations or places where we can send people to.
And Maria is asking how you coordinate your work with hospitals and individual patient organizations that are offering similar services, or this work is mainly done independently in parallel to all individual efforts. And by the way, she says that it's really a great work.
Thank you. Well, what we do, as I said, with respect to our national counseling cell, that's a context where every Tuesday morning we have an online meeting with the medical doctor from the Centre Hospitalier du Luxembourg. Maybe I'll go back a few slides. The Centre Hospitalier also runs what we call the Hub ERN. The Hub ERN is maybe a general entry door to the ERNs, to the European reference networks, where we can transfer a medical file or a request to the coordinator of that hub, and they would then dispatch the requests to experts within the hospital. That's one thing. We also collaborate with other medical doctors that are becoming slowly, too slowly maybe, but surely more regulars of our contact points. With other hospitals, it's a bit more difficult because they function on a different basis. So our main hospital is the main hospital from Luxembourg, the Centre Hospitalier. On the other hand, we also collaborate with a number of associations in Luxembourg. There are approximately a dozen of them here in Luxembourg. They are more working on a voluntary basis, but some of them also have a similar counseling service. And we have occasionally meetings together where we coordinate maybe common patient files, and we have, of course, all the GDPR requirements fulfilled of asking patients permission to share their data with the different stakeholders. For example, there is one association in Luxembourg about congenital heart disease, and we see their social worker, I think maybe 4 or 5 times a year to coordinate what we have in common in patients or solutions for problems, for questions. There is another association that has recently been incepted, which is called CASC, for the CASC disease, the same name as the gene that is involved in the disease. And their aim is to promote research and support scientific research. So we're helping them set up a collaboration with a private lab here in Luxembourg. So those are other facets of our work, maybe not always directly in relation to mental health and patients, but also maybe overarching objectives that other associations may have. I should mention that we also act as the National Alliance, and we are part of the Council of National Alliances for EURORDIS. So we have regular meetings over the year with the other associations in Luxembourg that we invite, and we break down information to their level so they understand better complicated issues like European legislation or national legislation, and we pick up their requests and we try to relay them to the political decision makers.
Thank you, Dan. I think we will go to Fatoumata, who will share her screen to share the recording that Nathalie did for us. So Nathalie Uhlenburg, who is, as I said, a psychologist and a researcher in Germany, and she set up and developed a program, a peer support program in Germany. And she couldn't be here today because she had another appointment, but she recorded a presentation of the program that she's working in for us. So we will just check and make sure that you can hear the sound coming from Fatoumata's computer. Do you hear Nathalie? And meanwhile, I will just read the example from Susanna, the comment from Susanna in the chat, who says that examples such as Alan Maladies Rares Luxembourg, together with national helplines and support services run by patient organizations worldwide, provide clear evidence of an unmet need. They show why strategic investment in psychosocial support is essential. So congratulations to this inspiring initiative, Dan. In Spain, they have a similar example through FEDER's information and support service, which demonstrates the positive impact of providing professional support to people living with rare disease and their families. So other initiatives in other countries.
So can you see my screen? No?
We can see your screen. We are on the slide of Dan.
Okay.
Hi there. My
Mhm.
name is Nathalie
We can hear
Ulbusch. I'm a psychologist and
That works. Thank you. That's great. Let's get to Nathalie.
researcher based in Hamburg, Germany. And unfortunately, I can't be there today, but thank you so much for the opportunity to pre-record this presentation so that I can tell you a little bit about the Curali project, which is an international trial that we've been conducting over the past years, which is about psychosocial support for people with rare. You probably heard about the results of the Rare Barometer survey by now, and these results clearly show the high need for psychological and social support of the rare disease community. But unfortunately, the clinical reality is that most people do not receive the support that they need. And the reason is that the care models or the care approaches that we have for chronically ill people fail to address the unique challenges of the rare disease community. They don't really know how to address that there are 8,000 heterogeneous rare diseases, so disease-specific approaches don't really work. They don't know how to address that people are often geographically dispersed, which results in what we can call the psychosocial care gap. Over the past 10 years, we in Hamburg, our working group, have been working on a way to address this gap by developing and evaluating support program for people with rare diseases, which is specifically designed to address the needs of the rare disease community. We developed this program based on a prior needs assessment, so we asked patients what kind of support they would wish for and designed the program exactly to meet these needs. The program is location independent, so people can complete it from home. It is trend diagnostic, so it can be applied across different diseases, addressing the shared challenges of the rare disease community, and it is delivered by trained peers. And we tried to close or at least address the care gap for people with rare diseases by providing scalable and evidence-based psychosocial support. Now, how it look like? It has two main components. One is structured self-help based on acceptance and commitment therapy, and the other one is telephone-based peer counseling. So participants who participate in the program receive a self-help manual which they complete from home, and it contains exercises, reflections on living with rare disease. And the content of this book is completely disease independent, so it addresses the shared experiences of people with different rare diseases. For example, dealing with difficult emotions, or disease acceptance, or turning towards what is really important for people. And the second component is telephone-based peer counseling. So after completing a chapter, patients receive structured 30-minute phone call with a peer counselor to talk about the experiences with the respective chapter. So we have 6 chapters, 6 telephone sessions, so it's a 6-week program in total. Okay, so who are the peer counselors? Peer counselors or peer supporters are people who are also affected by a rare disease, but who already found a really good way to deal with the disease and who want to help others in this process. And it is really important that peer supporters are adequately supported in their task. If they are, this task can really be beneficial for people. So we came up with a support framework. Peer counselors receive a 2-day training on site before they start their work as peer counselor. They receive counseling guidelines with additional information on the chapters of the self-help book, and they have supervision with a psychotherapist throughout the task. We then, of course, wanted to know if the program works and is actually helpful for people. So we conducted a first efficacy study already some years ago. We included 89 people with 4 very heterogeneous rare diseases. We conducted a randomized controlled trial with 2 groups. So we compared an intervention group who received the program with a control group who received care as usual. And we found that the program improved disease acceptance, mental quality of life, self-management abilities, perceived social support, feelings of helplessness, and it was highly accepted by patients and peer counselors. And we found these results quite remarkable, and we're really happy that such a short program can actually have an impact, a positive impact on patients. And so it was clear to us that we want to continue our work with the program, which now brings me to the EURORDIS project. The EURORDIS project was funded within the European Joint Programme on Rare Diseases within the Joint Transnational Call 2021, and we wanted to investigate the effectiveness of the psychosocial support program in routine care and then prepare the implementation into routine care. We did this across 5 countries. We had interdisciplinary teams at each site. So we focused on adult patients with rare autoimmune liver diseases. So we had hepatology experts and psychology experts at each center. And to our knowledge, this was the first international project to evaluate such a transdiagnostic support intervention specifically for people with rare disease. Now, what did we do? We conducted a 2-armed randomized controlled trial comparing the support program with care as usual, and our primary outcome was mental quality of life. We also conducted a program evaluation, so we asked peer counselors, patients, also healthcare providers at the respective clinics how they find the program, and we conducted focus groups with different stakeholders, patients, peer counselors, healthcare providers, and healthcare leaders to discuss if the program is implementable and how it could be implemented into routine care. We included 246 patients across 5 countries. You can see the cities that were involved in the EURORDIS project here. We in Hamburg coordinated the project, and then we had partners in Toronto in Canada, in Ghent in Belgium, in Debrecen in Hungary, and in Warsaw in Poland. So really diverse healthcare settings and healthcare systems. We recruited patients in routine care, 81% were female. This is quite typical for studies about psychological support. Women are way more open towards participating in these kinds of studies and also towards taking on psychotherapy or psychological support. And we included 3 heterogeneous rare liver diseases. Now let's have a look at the results, and I'm first going to show you the results regarding the primary outcome. Now what you can see here is the trajectories of mental health related quality of life, which was our primary outcome, in the 2 groups over time. So in blue you can see the trajectory of the intervention group, and in gray of the control group. At baseline, so at the beginning of the study, both groups were quite similar. The control group was even a little bit better, but this difference was not statistically significant. And then what we see here is that between baseline and the 8-week assessment, and in between the intervention group participated in the support program, we see a statistically significant increase in quality of life in the intervention group, but not in the control group. Unfortunately, this effect decreases a little bit over time then, but we still had a significant group difference at 20 weeks, but still we have to discuss how to make the program more sustainable, because people received only the 6-week program between baseline and 8 weeks, and then nothing else afterwards. And I think we clearly see here that it may be a good idea to add additional booster sessions or follow-up sessions here, but this is something we are discussing at the moment. So we can say that the psychosocial support program significantly improved quality of life across diseases and across countries. We also looked at now here you can see the secondary outcomes, which were also significant, or where we also found a significant group difference at 8 weeks with some effects sustained at 20 weeks. For example, depression severity, disease acceptance, perceived benefits through the disease, perceived social support, general self-efficacy and self-management abilities. We did not see any effects on physical quality of life measured with the SF-12, only mental. So we can say that the program not only improved mental quality of life, but also mental health, cognitive adaptation, self-management, and social support. We asked patients how acceptable or how helpful the program was for them. This is only a selection of items, but the majority said the program is helpful, that they would recommend it. It was important for them that the peer counselor also had a rare disease. The majority felt understood by their peer counselor. No one said the program harmed them. And we also asked the peer counselors, and they also said that they really benefited from this work, and that they would love to continue the work. So we can say that the program was highly acceptable to patients. And as I said, we also conducted focus groups with different stakeholders and in different countries. So in each country, we conducted focus group with patients, with peer counselors, healthcare providers, and healthcare leaders. And we had some consistent themes across countries and stakeholder groups, which were that the program addresses an unmet care need, that peer support is a key mechanism that is really helpful for patients, and that the program is scalable, but it needs infrastructure. So money was seen as a major barrier for implementation. So to summarize, the EURORDIS project found that our 6-week peer-delivered support program significantly improved quality of life and further relevant health outcomes. It demonstrated feasibility across diseases and diverse healthcare settings, and it was highly valued by patients and peer counselors. So for us, these results were quite remarkable, and at least in Hamburg, we are now at the moment implementing the program into routine care for patients with rare liver diseases, but we do not want to stop there. We want to try and make the program available to as many patients as possible, because I really hope that it can be a way to support patients in dealing with their disease and to at least not close, but at least address the psychosocial care gap. And I want to close with a quote of a patient that participated in the trial and participated in the support program, who said, "This program was so helpful. I was so stuck after my diagnosis and unable to look to the future without fear and despair. I feel like I can accept this as my new normal now and have the skills and strength to move forward and still have a good life." And with this, I thank you very much for your attention. Unfortunately, I cannot answer any questions right now, but please feel free to email me. You can see my email address here. You can scan the QR code and find me on LinkedIn if you want to connect and ask any questions there. And now I wish you a great rest of the webinar and a great day. Thank you very much for listening. Bye.
I will try to switch on my camera. We'll see if it works. Maybe we can stop sharing the screen. So on my side, I thank you all. I don't know if you have other questions that we didn't address or that we could ask to Natalie or send to Natalie, or questions on the survey or on the results. First of all, yeah, I'd like to thank you all for being here. I must say that it's the webinar that we had with the highest number of registrants, at least. Participants will see, but registrants, we had almost 300 registrants. So I think it is a topic that is quite important for everyone. I don't see any new question. I don't see people raising their hands. So we're probably done for today. Thank you very much. You have the links. You have access to the European results in 25 languages on the EURORDIS website. And patient organizations that are EURORDIS members, especially national alliances and European federations. In the upcoming weeks, you will receive by email to the contact that we have your results. And if you're not a national alliance or a European federation, just write to us at rare.barometer@eurodis.org, and we will send the results if you have enough participants. So thank you very much. Most of you here have participated in a way or another to the survey. So thank you also again for that. And well, see you soon.
Thank you.
very much.
Bye-bye.
Bye.